Hi, this is Kathy Kennett. I'm Vice President of Clinical Care for Parent Project Muscular Dystrophy, and welcome to the third of PPMD's series of 3 pulmonary webinars. This webinar is entitled Duchenne Pulmonary Care for Adults. Just a little bit of housekeeping. This webinar will last for approximately 60 minutes. All the audience members are on mute. You have a question box in the lower left side of your screen, so if you have questions, write your questions there. If possible, we will save the questions for the end of the webinar. This webinar, as well as the questions and answers, will be archived on the PPMD website. Before we begin, I'd just like to mention Duchenne Connect. As you are probably aware, Duchenne Connect is an online patient-reported registry that's supported by PPMD. If you've not registered, please do. And if you have registered, please be sure and update all of your child's information annually. The data collected in Duchenne Connect is used by clinicians and researchers to inform clinical trials and speed research. It's my pleasure to introduce today's presenters. Dr. Dan Sheehan is Associate Professor of Clinical Pediatrics at the State University of New York at Buffalo's School of Medicine and Biomedical Sciences. He also serves as Chief of the Division of Pediatric Pulmonology at Women and Children's Hospital of Buffalo and is Director of their Assisted Breathing Center. He and his team of respiratory therapists and physicians care for children and young adults with Duchenne, as well as other neuromuscular diseases throughout Western New York. Dan has been a consultant with the MD StarNet, which is the Muscular Dystrophy Surveillance Tracking and Research Network, since 2008, and is interested in identifying variations in respiratory care across the 5 states that the MD StarNet surveys. Our other speaker is Dr. Lisa Wolf, who's an Associate Professor of Pulmonology and Neurology at Northwestern University. Dr. Wolf is a member of the Neuromuscular and Sleep Divisions of the Adult Neurology Program. She has a career focus in the care of those with neuromuscular diseases and home-based ventilation. She has special interest in advocating for those with disabilities and has been a member of the Rehabilitation Institute of Chicago faculty. She's currently Director of Respiratory Care. Dr. Sheehan, if you'd like to start the webinar.
Sure. Thank you so much, Kathy. I am fortunate to work in a world of passionate pulmonologists who care for individuals with Duchenne muscular dystrophy. Part 1 of this webinar was early pulmonary care, co-presented by Dr. Richard Schell from Columbus, who I worked with back in 2002-2004. Part 2, middle pulmonary care, was co-presented by Dr. Jonathan Finder from Pittsburgh, who trained me in Pittsburgh from 1997 to 2002. And Part 3, I'll be co-presenting with Dr. Lisa Wolf, who I've been fortunate to attend a couple of her short courses at national meetings. Dr. Wolf is doing an amazing job training this generation as well as the next generation of pulmonologists who care for individuals with neuromuscular disease. So our topics for today, I'll be covering non-invasive and invasive ventilation and daytime hypoventilation. Some of this will be a review. I'll also be covering disaster preparedness, which I think is fitting today because I'm giving this webinar from home and looking out at about 4 feet of snow south of Buffalo and expecting 2 more beautiful feet of snow by tomorrow morning. Dr. Wolf will be talking about swallowing and speech difficulties, managing secretions, planning for transfer from pediatric to adult care, as well as how does a person advocate for themselves. So the next part is going to be a review for those of you that have seen Part 1 as well as Part 2. For those who haven't seen it yet, I would encourage you to go back and take a listen to it and watch it. It's just a wonderful series that they've put together. So this slide is the natural history of Duchenne muscular dystrophy's respiratory muscle weakness. And this is what happens with respiratory muscles without the clavichord or without prednisone on board. After a young man loses ambulation, sometime between 10 and 12 years of age, their cough becomes significantly weak. And then a little bit later, in the mid to late teens, they start to hypoventilate when they're asleep. Hypoventilation is just a fancy word for underventilation. When we breathe to bring oxygen in and to blow off carbon dioxide. And if we don't breathe deep enough when we sleep, then our body oxygen goes down and our body CO2 goes up. A little bit later, in the late teens to 20s, some individuals start to hypoventilate when they're awake as well. So they'll have a lower body oxygen number and they'll have a higher body carbon dioxide level. So there are signs and symptoms that give us a clue, and they give you a clue as far as if you have a weak cough, hyperventilate when you're asleep or hyperventilate when you're awake. So with a weak cough, if you have a persistent chest congestion or rattle, or if you find yourself throat clearing, something along the lines of this, that for some individuals with neuromuscular weakness, that is the extent of their cough because they're not able to take a big breath in and they're not able to squeeze their chest muscles, squeeze their belly muscles, and to produce a forceful cough. Some individuals that hyperventilate with sleep will have very restless sleep. They'll need to be repositioned. They may have nightmares. They may snore. They may sweat in their sleep. If your body's CO2 is high when you sleep, some people will have morning headaches. Some people will need to take daytime naps, and there may be some mood changes as well. And then we always ask about changes in school performance for young men that are either in high school or in college. With hyperventilation when someone is awake, well, they may have this just general sense that they're short of breath. They may be anxious. They may have a soft voice. And they need to breathe even during very, very short sentences. Now, as Dr. Finder and Dr. Kupfer relayed in Part 2, weak cough and hyperventilation asleep and awake can occur without symptoms. So it's very important that after someone loses ambulation, that at least twice yearly they have their pulmonary function evaluated. And this is part of the 2010 care considerations that many of you may know about. So let's look at the left-hand part of the slide first. So the way we look for weak cough is one of the things that we do is we look at somebody's peak cough flow, PCF. And that's basically using an asthma peak flow meter and having someone cough into it. And when it falls below a certain level, you may remember something along the lines of 270 liters per minute, then it suggests that someone will have an ineffective cough. MEP is the maximal expiratory pressure, how much pressure you can generate when you squeeze your chest and squeeze your belly as hard as you can. And then vital capacity is one of the measures that we follow commonly, and the vital capacity is the total amount that you can blow out after breathing in all the way. And there are values of the vital capacity that is suggestive of perhaps someone's cough is weak. As far as hyperventilation asleep, well, we can do sleep studies where we look at either body CO2 or saturation. So the PET CO2, that stands for end-tidal CO2. And end-tidal is just another way to say that, well, what is the CO2 at the very end of the exhalation? The SpO2 is the saturation. We'll talk a little bit more about that in the next slide. And then again, there are kind of red flag vital capacities when we know that somebody is going to be at higher risk for hyperventilating when they're asleep. And then hyperventilation when somebody's awake, well, really the best measure is the measure of body CO2, but we also look at saturation of oxygen as well. So in our body, we have red cells and we have white cells. The white cells fight infection, and the job of the red cell is to carry oxygen to the muscles of the body. And within the red cells, we have hemoglobin. And so the oxygen saturation is just a measure of how covered that hemoglobin is with oxygen. So if the hemoglobin is totally covered with oxygen, then the saturation is 100%. And the normal range is about 96 to 100%. If our muscles are weak when we breathe, or if, say, we hold our breath, then the oxygen saturation will fall and the body CO2 level will increase. And right around 95% saturation is where we get significant increases in body CO2. And when our body holds on to CO2, it's like holding on to acid, so our body doesn't function as well. And so with individuals with purely muscle weakness, when their saturations are 94, 93, 92, and below, then their CO2 levels are too high. And it's very hard for their bodies to function maximally. One of the things that sometimes is a little bit confusing in the emergency room or in the hospital is that there's a lot of, the most of what we see are individuals with either asthma or pneumonia. These are individuals that the oxygen saturation that is kind of our goal oxygen saturation for them is about 92, 93%, because they have the muscle strength in order to keep the CO2 level at a good level. So it can be kind of confusing when you hear people use different saturations. So that, you know, when we have an individual that has respiratory muscle weakness, we aim to have their saturations above 95 or 96%. And if it does tend to be lower than that, then we really should be checking their body's CO2 to make sure that that hasn't increased. Actually, I'm going to go back a couple slides. What I wanted to say on this slide is to look at the right-hand side of the slide. You know, when we do pick up a weak cough, we have the cough assist that can be used to help somebody cough. We have, for hypoventilation when somebody is asleep, we have non-invasive ventilation, which means we can help ventilate somebody with just a mask over their nose or pillows in their nose. And then as far as hypoventilation when someone's awake, we can offer what's called SIP ventilation. You see the young man with a mouthpiece, and at the other end of that mouthpiece is a ventilator where they can, on demand, take a breath of the size that they want, and they can actually stack breaths as well with it. So kind of the red flags that tell us, you know, we should really look closely whether somebody needs non-invasive ventilation when they're asleep is when the vital capacity falls less than 30%. Medicare will allow us to prescribe a non-invasive ventilation if someone's vital capacity is less than 50%. But for many people, it doesn't become a need until the vital capacity is less than 30%. We also look at how well they're able to generate a negative pressure, the maximum inspiratory pressure, when they're able to breathe in. And we also look at body CO2. The normal level is around 40, but when it's above 45, that suggests that someone may not be ventilating well when they're asleep. And then we look at the daytime saturation as well, and we talked about the 95 to 96%. Depending on the area that one lives in, you can either do a sleep study in the hospital, or you can do home studies where you can either monitor someone's oxygen saturation overnight or their oxygen saturation as well as their CO2 level overnight. So there are many types of devices that deliver what's called high-span BiPAP. And what BiPAP is it's two levels of pressure, where you have an inspiratory pressure that gives you extra pressure when you breathe in, so you can take a big breath. And then there's an expiratory pressure that's in the background to keep your airways open in between breaths. The inspiratory range is typically somewhere between 16 to 22, and the expiratory is 3 to 6. So that's where you get the high span with it. And as some of you may remember, it's important that there's a backup rate, because probably somewhere between 12 and 20, because some people, when they hypoventilate, when they sleep, often pause when they sleep as well. So it's good to have a backup rate so that you get those extra breaths as well. And what you see on the slide is a bunch of different devices, and I think what's most important is what your local home care company as well as your hospital are familiar with. And I think that's probably the most important as far as deciding which type of device to use. The two on the top are BiPAP machines. The two on the bottom are ventilators. Probably don't need a ventilator when you can get by with just a BiPAP machine. And just like there's many different types of devices, there's many different noses that are out there. So we have many different types of interfaces as well. I think I made this slide about 2 to 3 years ago, and since then, there's even more types of devices. You'll see on the left-hand side, we have something called pillows, and then on the right side, you'll see something, you'll see what a nasal mask looks like as well. And again, there's many, many more different types of interfaces. So don't give up after the first attempt with BiPAP. Give it at least 2 to 3 times, because you will be able to find an interface that works best for you. Well, what about non-invasive ventilation when somebody is awake? Well, we have the daytime SIP ventilation, and it's more likely to be needed when the vital capacity is less than 680 mLs, or 15% predicted. And what I would say is that these are just a range of values, because I have young men with vital capacities of 300 to 400 mLs. Some have seen corticosteroids, some have not, and they don't necessarily need daytime SIP ventilation. And that's why it's real important to get those measurements of body oxygen and body CO2, because these numbers for the vital capacity really are just kind of a starting point for us to start looking closer. We also use daytime SIP ventilation if the awake body CO2 is greater than 45, and this is despite using non-invasive ventilation with sleep. Often if we correct hyperventilation with sleep, daytimes and we rest people with sleep, their body oxygen and their body CO2 levels will be right on during the day, and they won't need daytime SIP ventilation. And again, with the SIP ventilator, we're able to have volume breaths, so you can actually stack the breaths on top of each other, so you can stretch your chest wall as well as stretch your respiratory muscles, which I think is real important to maintain flexibility. And so, again, there's a number of different types of ventilators. There's a number of different types of mouthpieces. Many ways to make SIP ventilation work for you. Well, when should invasive ventilation be considered? And what invasive ventilation means is that it's ventilation by way of a tracheostomy tube. And so a tracheostomy is a hole in the neck, and then there's a tube that can be connected to a ventilator. And in the 2010 DMD care considerations, I think the most important thing is really an individual's preference of whether they want non-invasive ventilation or they want invasive ventilation. There's a wonderful resource that Kathy Kinnett shared with me, and I got an email just yesterday from one of the authors of Ventilation in Duchenne, put out by DMD Pathfinders in the UK. And it really is a wonderful resource and gives you an individual's perspective of what non-invasive and what invasive ventilation is like. For example, John Hassel started using non-invasive ventilation in his early 20s, is now 33 and using it 24 hours a day. Mark Chapman started using NIV in his early 20s at age 26, but decided to switch to tracheostomy and a ventilator and is now 44. So this is a wonderful resource as far as perspective, as well as the different ways that we ventilate. The terminology is a little bit different in the UK. They'll talk about a ventilatory clinic and respirologist. Here in the United States, we talk about a pulmonary clinic or assisted breathing clinic and a pulmonologist and a respiratory therapist. In this wonderful resource, they talk about the importance of seeing a physician when you recognize the symptoms. I just want to again reinforce that it's really important after losing ambulation that you have pulmonary function tests done at least twice a year to get a sense of where your respiratory muscles are and whether you're hyperventilating with sleep or whether you're hyperventilating when you're awake as well. Also within the care consideration, they talk about invasive ventilation should be offered when the individual cannot successfully use non-invasive ventilation, when the local medical infrastructure does not support non-invasive ventilation, depending on what the home care companies are able to supply. Also, if there's been 3 failed extubation attempts after being intubated for a respiratory illness, despite optimal use of non-invasive ventilation as well as the cough assist, and we'll talk a little bit about extubation protocols in a little bit. As well, if there's a failure of non-invasive methods to prevent aspiration of secretions, and Dr. Wolf will be speaking a little bit more about that as well. So as Kathy Kinnett had mentioned, I've been working with MD StarNet since about 2008. MD StarNet is the Muscular Dystrophy Surveillance, Tracking, and Research Network. It's a population-based surveillance system that identifies all males born on or after January 1st of 1982 who have Duchenne or Becker muscular dystrophy in Arizona, Colorado, Georgia, Iowa, and Western New York. And it's funded by the Centers for Disease Control and Prevention, the CDC, and was really came about as part of the MD CARE Act legislation that PPMD has played a key role in advocating for, as well as advocating for its recent reapproval. And as Kathy might have mentioned, one of the important things for me with MD StarNet is not only getting a sense of how prevalent Duchenne Becker muscular dystrophy is, but also whether there is variation in care. And we recently looked at we have some preliminary data about tracheostomies in MD StarNet, in the 5 states of MD StarNet. And we looked at 2-year periods, and we looked at the number of new tracheostomies performed, and whether they were performed with acute respiratory illnesses. And so in MD StarNet, I think we have around 400 to 450 young males that would be in the age range where they might need non-invasive ventilation. And what we found was that at least 50% of the tracheostomies in all of the 2-year periods were performed with acute respiratory illnesses. We also looked to see whether these individuals had a copocyst, also known as a mechanical insufflator, exsufflator, an MIE, or whether they had non-invasive ventilation before tracheostomy. And what we see is a nice increase in the use of an MIE or copocyst before tracheostomy. However, even in 2010-2011, individuals did not all have a copocyst before tracheostomy. We've seen a more recent increase in the use of non-ventilation, but despite this, individuals still required a tracheostomy. And, what we don't know is whether there is a weaker subset of males with DMD where non-invasive modalities might eventually fail and they would require a tracheostomy, or whether there's optimal use of a copocyst in non-invasive ventilation and extubation protocols that resulted in tracheostomies that perhaps might have been preventable. Yesterday I received some data from Duchenne Connect, and Duchenne Connect is a wonderful registry where it keeps track of about 1,500 individuals with a DMD in the U.S. Within these 1,500 individuals, 33 had tracheostomy. 16 are using a ventilator all the time with either a face or a nasal mask. And of those 33 with a tracheostomy, 8 of the 33 used it with steroids. They had tracheostomy, had a history of using steroids, and 25 of the individuals with a tracheostomy reported never using steroids. So, even individuals that use steroids at some point in time may need the option of a tracheostomy. And in this group of 33 individuals, the age that they currently are between 21 years of age to 52 years of age, where the average is around 34 years of age. Okay. So I spoke a little bit about extubation protocols. Well, since 2005, when we really started our learning curve in Buffalo about how to care optimally for individuals with neuromuscular disease, such as Duchenne or spinal muscular atrophy, we've been using an extubation protocol for all our neuromuscular patients after they've had surgery or when they've had a pneumonia or lower respiratory infection. And this extubation protocol was adapted from the work of Dr. Mary Schroth in Madison, Wisconsin, who works with SMA, as well as an extubation protocol that was published by Dr. John Bach from New Jersey for SMA. Dr. Bach has a newer extubation protocol with some modifications that he published in 2010. And one of the key things about the extubation protocol, which is really a change in culture within an ICU, is that, before extubation, you really use the cough assist every 4 hours or when you have a drop in your oxygen number. And then you start to consider extubation when the patient is without fever, not requiring supplemental oxygen, which means they're just on room air, but being ventilated at the same time. Their chest x-ray is without areas of consolidation. They're off all respiratory devices, so they're not drugged in a way that they can't use their respiratory muscles optimally, and they have minimal secretions as well. And when somebody's extubated, they're extubated to high-span BiPAP and very frequent cough assist. My respiratory therapist wanted to make sure I reminded people that, that first 1 to 2 hours after extubation is really a key point as far as possibly needing the cough assist up to every 5 to 10 minutes. And it's usually kind of a bump in the road, and then they do much better after it. I think once the tube comes out, there's still a lot of secretions that need to come out. So don't be surprised after extubation if the first hour, 2 hour, 3 hour have some bumps as the secretions are being removed. Okay. This is a Blizzard of 77 travel game. I've been back in Western New York for about 10 years. This is my second 4-foot snowfall. But, here in Buffalo, we've not really cornered the market on all of the natural disasters. We're rarely affected by hurricanes, tornadoes, or ice storms. And as Dr. Schell had said in, an earlier webinar, emergencies happen, so we all have to, hope for the best, but also prepare for emergencies. It's when you have a cough assist, when you have a ventilator, when you have non-invasive ventilation, it's important to have a backup generator if you are in an area where there's the chance for electricity to go up. Some of our young men that live in rural Western New York have had fundraisers in order to purchase a backup generator. You also need to have a sense of what your equipment batteries are. For example, the Trilogy ventilator, each of the battery packs lasts for only about 6 hours. The Respironics cough assist will last for 6 treatments. In addition, the older cough assist and the LTV, if you are going to use it to get to the hospital, you'll need something called an inverter for your car or your van. So you've not only got to think about, how do I stay safe at home, but how do I get to the hospital safely for any respiratory illness or if you have, a wonderful natural disaster in your area. And so that's why one of the key things may be to get to know your local emergency medical services. And, my friends that are out in rural Western New York have taken this to heart and have educated and also appreciated their EMS with holiday cards, Thanksgiving cards. And there's nothing probably more powerful than a box of Tim Hortons donuts to really get your EMS on board. One of the things that we have to keep in mind is that all the EMS vans may or may not have electrical outlets. So it'll be important to get a sense of whether the EMS vans in your area do have an electric outlet so you can use the cough assist on the way in, so you can use your ventilator on the way in or your non-invasive ventilator as well. So as far as disaster preparedness, it's always important to bring your own equipment with you. I'll show you the PPMD emergency card in a second. It's also important for actually everybody that's listening to this webinar who's an adult to have a healthcare proxy. Have somebody designated that knows what you want done and is able to make those decisions should you need to be intubated, should you need CPR, or other means of support. Everybody listening to this webinar should have one of those. In addition, I think it's also very important to call your neuromuscular doc, your cardiologist, your pulmonologist, or your respiratory therapist. Either call yourself, have a partner call, or a family member. We're not always called, and there have been times when when the family has been told that we would be called and we weren't called. And this happens actually with some of our kids with other lung disease as well. So don't hesitate to let your neuromuscular doc, your cardiologist, your pulmonologist, your RT know that you're coming to the ER or that you've been admitted to the hospital. This is an example of the PPMD emergency care card. You'll see that for respiratory care, they talk about the importance of not giving oxygen without checking a body's CO2 level, and the fact that non-invasive ventilation may be required. Again, before giving oxygen, it would be great if people supported ventilation first if the CO2 level is increased. Back in January of this year, Kathy Kinnett, Dr. Jonathan Finder, myself, and our respiratory therapist worked on avoiding the emergency room block, and that's the directions to it. In addition to having our patients take with them their equipment, they also take this sheet in a plastic sheet to share with the emergency room or the EMS. And it talks about the importance of the cough assist, explains that, if the oxygen number is low, probably need to get mucus out. It talks about not just using oxygen without using something like BiPAP or checking CO2. Talks about the importance. And then right there it has the list of the neurologist phone numbers, the pulmonologist, the cardiologist, as well as the respiratory therapist numbers as well. So again, these things probably are downloadable. If not, through Kathy, we can get you copies that you can adapt to yourselves as well. So I think I went kind of fast, but there will be time for questions at the end. And I'm going to hand over to Dr. Lisa Wolf, who's going to be talking about swallowing and speech difficulties and secretions, transfer of care, as well as advocating for yourself.
Thank you. That was great. This is Lisa Wolf, and I'm just going to get straight into it so we don't lose out on time here. And so we're going to go to the section on swallowing first. When we talk about swallowing, we need to divide it into separate parts. There's differences between fatigue with eating and aspiration with eating. We're going to talk about the differences between the two. We're going to talk about the role of speech therapists and the role of feeding tubes. First of all, in terms of fatigue and eating, what I first want to do is review what it takes in order to eat. So regardless of whether or not you have neuromuscular disease, breathing and timing of breathing is involved in eating. If you look at the graph that you have in front of you, what you will see is that you have a description right here of what goes on during breathing while you are swallowing a liquid. So there's a nice phase that's in blue here of take a big breath in to inhale. After you finish your inhaling here, you will initiate your first breath. That first breath will allow you to go into a breath holding pattern. You're not breathing in, you're not breathing out. During that time, you'll have second, third, and even fourth swallow if you're strong enough. And when the breath is out and you can no longer breathe, you will stop swallowing and allow yourself to exhale. Okay? Which means in order for you to breathe, you've got to have strong enough muscles to take that big, big breath in, and in order to allow yourself time to swallow, and in this case you don't have to chew, but if you were chewing, allowing time to both chew and swallow, you have to hold your breath for a significant amount of time. And you'll notice here that this can be almost 10 seconds depending on how long you're going to be swallowing or how strong your breathing is. And the analogy that I have here is that if your lungs are not completely expanded and you are trying to breathe and swallow, it's like running a 100-yard dash, but someone asking you to start 6 yards before the starting line. If we can improve the inflation of the lungs, we can improve the amount that you are able to swallow, reduce the energy that it takes in order to swallow, and make the process of eating less fatiguing. So if you look at the next slide, what you'll see here is something that we call breath stacking. Now, this is a boy with Duchenne muscular dystrophy who's actually in Brazil, so the language on here is Portuguese, so I'm going to just leave that there. But what you will see is that the caregiver here has something called a resuscitation bag or an AMBU bag. The role of that AMBU bag is to allow a bigger breath to be introduced into the lungs than the boy with muscular dystrophy can take on his own. The process here is called breath stacking or lung volume recruitment. And lung volume recruitment means that the lung itself is fine. It's just that you can't get a big enough breath to use it. And when we use something like this AMBU bag, you will be able to recruit that lung so that you start from a bigger breath so that your swallowing can be improved. Now, the data to show that this works comes from Stuart Cleary, who's a speech pathologist. And this is actually his data looking at those with ALS, but the process is probably pretty similar in any neuromuscular disease. What you'll notice is that this is the baseline prior to any lung volume recruitment maneuver, and the amount that you will have of your breath prior to swallow is relatively small, which means that it's going to be much more fatiguing when you're trying to swallow. After the patient has had some time to stack up those breaths and increase lung size, you will then be able to swallow with lungs that are much more inflated, meaning that you're going to have a longer time and be less fatigued with swallowing. What we are currently recommending is that if you're going to schedule your lung volume recruitment procedures during the day, either with a cough assist or an AMBU bag or any way that you're going to be inflating your lungs, try to schedule it just prior to your meals in order to reduce fatigue and allow you to swallow better. Now, swallowing is not just all about relieving the fatigue. Swallowing can also be about the muscles specifically in the throat. So what you'll see in this cartoon is that this is a side of the face as if it's been cut in half. You'll see that the water here in the glass, as it goes through, will have two directions to go. It can either go into the stomach where it's supposed to go, or if it goes the wrong way, it will go into the lungs. And that's what you're seeing happen right here. If the food goes the wrong way and it lands in the lung, that can drive infection. And chest infections are the enemy of any patient with neuromuscular disease. Now, there are two ways to see whether or not this is happening. You can either do this test, which is a fiber optic endoscopic evaluation of swallowing, and most of the time you'll hear it referred to as a FEES. In a FEES test, there will be a fiber optic scope like this one, which basically is a very thin fiber that's about as big around as a pencil, that has attached to it a light and a camera that can look at the vocal cords and see whether or not, as you are swallowing, is there food passing or liquid passing through the vocal cords when it shouldn't be. The alternative is to do a video fluoroscopy or a video swallowing study. Sometimes we call that a VFSS. And with a video swallow study, there are liquid or cookie or eggs that are infused with a little bit of a barium-type dye. And you'll see here that the dye shows up on a videogram, and you can see that bolus of food going down the wrong direction. And this can be one way that we get an idea of whether or not there is good function to the swallow. What's very interesting is that if we look at data from patients with Duchenne muscular dystrophy, what we find is that at the early ambulatory portion, there are many patients who will have very little in the way of abnormality. If we look at solid food, which is in the red, versus water or semi-thick liquids, you'll see that those with ambulatory problems are very much excuse me for the sneeze, very much only minorly impacted However, if you advance and look at late non-ambulatory stage of Duchenne muscular dystrophy, you'll notice that many of the swallowing attempts are affected by this problem, and that there's a much more frequent number of swallows on video swallow that are likely to be impacted and abnormal. The problem that we end up with is, when is it appropriate to send someone for further testing? We know that it gets more frequent with age, but we also know that there are some patients who may be impacted even to early periods of the disease. If you look at symptoms, and on this graph here you'll see that these are all symptoms, we know that if we just look at a single symptom, we are not likely to see an abnormality in swallow. So for instance, if we just looked at every patient who had a chest infection without any other symptom, and again the numbers are small here, you may not see an abnormality. But if we add chest infection to a secondary problem, like weight gain issues or choking issues, then you'll see that many more of the patients have a specific abnormality on their swallowing study. And so the rule of thumb is that a swallow study should be performed in a patient with Duchenne muscular dystrophy if they have a chest infection plus any other symptom. That being said, there's this concept called one-off. And what we mean by one-off is that if the patient has a history which is really bad, it's important to start talking about alternatives. And what do we mean about a bad history? By that we mean that the patients had an episode at home that scared their family, scared them, scared caregivers, in which swallowing was so dysfunctional that there were obvious choking, difficulty relieving the choking, and if that's the case, many will advocate that it's time to start talking about changes, that we skip the video swallow and go straight to therapy. And that's something that needs to be initiated as a discussion with one's doctor. But it's important to know that if they do decide to go for a video swallow, you will get important information. We'll see whether or not it takes a long time for the patient to chew because muscles are weak. We will know whether or not that bolus of food has trouble getting down where it needs to go. We know that that's worse with age, as we said before. And so we're going to have to make those decisions on a case-by-case basis. Now, after that video swallow has been completed, or after a meeting with a speech therapist is completed, a speech therapist may make many changes that a patient can make to make things better. The speech therapist may note that in any given patient with muscular dystrophy, positioning of the head and neck may help to improve the way that they swallow. They may notice that water or juice or any other thin liquid is the problem and that everything else is okay. And it may just be that avoidance of these trigger foods can be helpful. Sometimes adding thickeners to that may be a good solution. In addition to the thin liquids, sometimes we find this difficulty with moving the food bolus if the food is dry and crumbly and difficult to have a good adequate volume. And so you may need to avoid those. Switching to foods that are cooked and softer, avoiding raw, crunchy foods may be helpful as well. And we'll frequently suggest multiple small meals to help reduce the fatigue that can come with having very large meals, because the less fatigued you are, the better you're going to eat. A speech pathologist may find that something like a straw or a cup may be helpful or it may be harmful, and you need to be watched by a speech pathologist before making those decisions. And of course, the use of smaller spoons means there's smaller portions, and smaller boluses cause less fatigue and less difficulty with eating. And then what I want you to notice on this graph, which is from Dave Bernkrat from Cleveland, who's done a lot in terms of care for those with Duchenne muscular dystrophy, is that if you look at non-cardiopulmonary complications in long-term adult patients with Duchenne muscular dystrophy, the most common finding that he found was issues with dysphagia and malnutrition. And he strongly recommends that the placement of a tube into the stomach can be helpful therapy for those patients and should at least be considered as an alternative for patients that have that problem. Now, what is a feeding tube? A feeding tube is a tube that is placed directly into the stomach, and even though the opening of the tube is here in the stomach, there's an alternative opening out here outside the stomach in which solutions or other types of foods can be blenderized and placed in so that they can go directly to the stomach, avoiding the fatigue of chewing or difficulty with swallowing. There are advantages to having such a tube, the biggest of which is reduction in chest infections, because food that goes the wrong direction is frequently going to be host-friendly for bacteria that can build up in the chest and cause that kind of pneumonia. And, of course, pneumonia being the biggest enemy to patients with weak muscles like Duchenne muscular dystrophy. We also know that our patients who get fatigued with eating require a lot of supplemental nutrition because they don't get the quantity of food that they need. So we can supplement their food with higher amounts of extra calories. They also don't get the quality of food they need because the truly rich protein foods and foods with vitamins and minerals are often the most difficult to effectively eat, so that we can improve the amount of protein or nutrients that go through that tube. And ironically, we would want that to be with high-fat foods. I often say I love my job. I'm the only adult physician that I know of that gets to say to my patient, no matter what you do, don't lose weight and make sure and take in extra fat. And the reason for that is that we know that foods that have a higher percentage of fat will be easier on the lungs. Easier because they make less carbon dioxide, so there's less carbon dioxide to breathe off. We also know that improving hydration is important, and we can put water straight through that tube because if we don't adequately hydrate patients, they get constipated, and if your breathing is difficult now, imagine what it's like to breathe against a distended belly with constipation. We also know that keeping adequate hydration will thin chest secretions and saliva, meaning that they won't just lay there in the lung. You'll be able to more easily liberate those secretions and keep them from building up, causing chest infections. How do we get those tubes in? Well, we have lots of options for what kind of tube and how they're placed. So, for instance, you'll see here on the screen, this is a let me see if this thing will let me pick it up. There it is. So this that you're seeing right here is a radiologically inserted feeding tube. Sometimes we call that a RIG, or a radiologically inserted G-tube. You'll notice in the series of drawings here in the top corner, you'll see a needle going into that black sac. That's the lung. And you'll see in this corner that there is a dilator that goes in after the needle in order to make the track. And then lastly, you'll see in this third panel that there is a little bump inside the dark sac. That's actually the tube itself. Alternatively, the tube can be placed by a gastroenterologist. We call this a PEG, or a percutaneous endoscopy. What you'll see here on this figure is a tube with a camera and the light at the end of it, which is used to place that feeding tube right into the stomach, coming out the abdominal wall. Now, what kind of tube can you have? Well, sometimes we call this the Mickey versus Minnie debate, and I'm not talking about Disney here. The Mickey is a common tube. It lays flat against the stomach. We have an even smaller one now called the Minnie. Initially, you may find that you require a longer tube like this one. I always say that the placement of feeding tubes is kind of like women getting earrings placed. You need to have a longer tube like this one here at the top in order to establish and heal that stomach port between the abdominal wall and the stomach. And once that area is well and healed, you can change it out for as many tubes as you like. And so you can think about which options you want in the long term. Now let's talk about managing some other kinds of secretions because we're getting short on time here. Nasal, oral, and chest secretions. Now we've talked a ton about chest secretions, so I'm going to try to focus more on the nasal and oral secretions. So for nasal secretions, it's important to know that nasal secretions are kind of like your garden. If your garden is too dry, you have to wet it. If it's too wet, you need to dry it. What are some of the drying agents that we can use? Typically, we would use sprays, but we know in neuromuscular patients that can be a challenge because they don't have strong enough inspiratory strength in order to spray those sprays where they need to go. And that's why you're going to see a big don't do it there on the sprays. In addition, we typically use pills. Pills, like you're going to see in the corner there with the picture of the Claritin D, the problem isn't the pill itself. The problem is the decongestant, or the D. So sometimes I say D stands for just don't do it, and that's because in the setting of Duchenne muscular dystrophy, cardiac disease is a significant worry, and these types of medications can make arrhythmias worse or heart rhythms, and so we suggest avoiding those kinds of drying agents. What can you use as alternatives? Alternatives, you can use something like the little sucker. Now, in this picture, you'll see a little sucker, and the little sucker, which is here in this picture, is being used on a little baby doll. But in a boy or a man with Duchenne's, this can also be used to put in the nose and suck out those secretions. Or you can use your cough assist, and that's what you're seeing in this picture over here. This is a boy who's using his cough assist as a full face mask. You take a deep, deep breath in, and when you take that breath in through your mouth, when you're ready for the exhale portion, you close your mouth and blow out your nose, and the cough assist will help to clear that nose out. Now, if the secretions are too thick, then what you need is to humidify them. And humidity and antihistamines can easily be taken. The antihistamines would be like a straightforward Claritin or Allegra, whatever you can easily get over the counter. Or you can mist using something like this, which is a tabletop mister. Now, this is a fancy thing that women like because it helps to keep the skin looking young. You can easily do this as well by just taking a boy into the bathroom, turning on the shower, and just letting it steam and allowing them to get some steam up into that nose and help to clear things out. The next, we want to talk about oral secretions, and the reason that we want to talk about oral secretions is that if you are using supplementary feedings and you are not doing 100% oral feedings, we find that there's a significant number of pathogens which will be found within the oral cavity, specifically in the gingiva or the gums. So that oral hygiene is the number one thing that you can do to keep bacteria out of the lungs. And how do we do that? Well, the first thing is to improve oral care. We can use things like Sage kits, which are down here, that include both chlorhexidine toothpaste. The chlorhexidine is really important for killing the bacteria, and the toothbrushes here have a port that allow them to attach to suction, so that if you choke on secretions, you can still get the toothpaste in there and you can clean well without risking aspiration. You also need to locate a very disability-friendly dentist. You'll see here in this picture that this dentist has the ability to treat this boy while he's still in his power chair, because being placed in the dental chair would put him in a really position that would not be good for breathing. And we especially get worried as we have men with muscular dystrophy, because now we have to worry about how to get wisdom teeth out. And so getting that relationship with a dentist is very important. The gingival care is key because that's where this bacteria hangs out. And if you can't easily get into those areas to clean them out, there is a device that's called air floss. And you're seeing a picture of that here. And the air floss can help to keep food particles out and help to clean the gingiva, even if you're not eating, to keep down the buildup of bacteria on those areas. Also, don't forget that we also need to keep this clean, because as boys develop cardiac disease, we want to keep healthy valves And if you have the placement of something like a pacemaker or an AICD or electric shocker, good oral hygiene helps to prevent any infections in the heart as well as the lungs. Next, in terms of chest secretions, you've already heard a ton about devices like cough assists, but what I'd like to talk about is some simple things that we can do to help alleviate chest secretions. Think more about seating and positioning. Do you have a good power chair that fits you well and helps to keep you in a vertical position? Because the better your seating and positioning is, the better your cough is. Do you have scoliosis? If so, does it need to be repaired? We know that repair of this kind of a scoliotic chest or back will help the chest wall work better and allow you to cough. If you have weak core muscles, the addition of an abdominal binder, and this is a picture of an abdominal binder here, helps to strengthen the core to allow you to cough by yourself more easily without devices, helping to keep down those chest secretions. Now, the other thing is that the pulmonologist frequently ends up being what I call the poop police. Whenever you're using a power chair, just being in a chair increases the amount of constipation that you have, as you can see in this chest x-ray. Constipation is the enemy because it's much more difficult to cough and breathe against a distended belly. And those of you doing non-invasive ventilation, aerophagia, or the swallowing of air, which is what you see right here, can also distend the belly and make it difficult to breathe against a distended belly or cough. Those are the kinds of things that you can work with your physician to help you to better handle those problems. Lastly, if you truly are having reflux or heartburn, it may be that you need an adjustment in tube feeds, an improvement of constipation, or aerophagia control. And all of these are important for handling chest secretions, but have not previously been discussed in this series. We want to talk a little bit about control of kyphoscoliosis. In general, we know that spine films are recommended once a curve is more than 15 degrees, and that those should be performed at about every 6 months. We should consider surgical repair in those that are good candidates. And for this, we typically use what I call the 30-30 rule. And the 30-30 rule says that if the Cobb angle gets to be greater than 30% and the patient's vital capacity is also greater than 30%, then you're a good candidate to have that repaired. There are some situations in which we can say that the vital cough under 30% can still be done, but it would need to be done with a lot of aggressive support of non-invasive ventilation. We know that this makes a difference because if you will look here, patients who have spinal surgery and support of non-invasive ventilation survive much longer. If you forego spinal surgery or the support of ventilation, the life expectancy for a boy with Duchenne muscular dystrophy is significantly impacted. And what seems to be driving that is this change in vital capacity that can occur if you are untreated. The truth of the matter is, this is changing ground. What we've noticed is that although there was an extreme uptick in the number of boys who received surgery as scoliosis therapy through the mid-'80s, through the mid-'90s, what we're seeing is that now there's a downtrend into the number of boys that are getting scoliosis surgery. And we don't think that it's because doctors have lost faith in the surgery. What we think is that the number of patients are fewer. In this diagram, what you will see is that the use of steroid therapy has reduced the amount of scoliosis. And those that have had steroid therapy, the number of patients with scoliosis is much less as compared to those who had no treatment with steroid therapy, for whom the number of patients with scoliosis is significantly increased. Because of that, we do think that this may be less and less of an issue. So, how are we going to plan? Oh, we've got 2 minutes. How are we going to plan as transfer to adult care? When to start planning? We think that patients should start planning in their late teens. Identify your adult providers and have your pediatric providers invite them to pediatric clinic so that they can get to know you and your treatment. Identify what are your goals. If you want to go to university, let your team help you to start making those goals a reality. And think about what are the vocational services that may be available to help you with that. I'm not going to have time to go through it, but one thing that we use as a tool to help boys with Duchenne's to make these decisions with their physician and caregiver teams is to take something called the HEAD survey, and the HEAD survey involves all of the questions that you see below there and what are the questions that we need to ask in order to come up with a good plan. Advocate for yourself. The first is dealing with your DME or your home care company. Learn your own equipment and how it works, and learn to work with your own caregivers, because directing your care is the way that you are the most liberated and the most free. And as parents, one of our really important jobs is that we teach our children with disabilities how to advocate for themselves by communicating directly with their personal assistants so that they get their care needs met. In the end, this will allow them to be free, independent, active in the vocation of their choice, and have the best options for independent living. And lastly, make sure that as you transition to adult care, you yourself learn how to download and look at your home-based ventilation equipment. This is one example of a download and how it works, so that you know yourself without asking anyone, is my mask fit okay? Are my breaths big enough? And am I using my device at the target hours that I should be? So hopefully we've left at least a minute here for questions, and I'd like to turn it over to our moderators to see if we have any time.
Thank you so much. That was really excellent. So much information and really excellently presented. You must have done an incredible job because there aren't any questions.
Great.
Or I haven't gotten any questions. Danielle, do you see any questions?
Nope, there aren't any.
Nope. Okay. We are at time, so I would like to thank our presenters. If I receive questions after the webinar, I will forward those and we'll include the questions and the answers with this archived webinar. And again, I just want to thank Dr. Sheehan and Dr. Wolf for this excellent presentation, excellent information. This concludes our webinar.